Welcome to Lifestyle Disease Doctor. This is the third in the four-part series on chronic kidney disease. In this 30-minute episode, you will come to have a picture of what are the associated comorbidities that are normally found in kidney patients and also the complications that usually come during chronic kidney disease. To make things clearer to us, we have Dr. Jolly Thomson, and with her 35 years of experience in treating chronic disease patients and including chronic kidney disease patients, we hope that you will get a better picture, a clearer picture on the impact of even lifestyle corrections on these patients. To begin with, Dr. Jolie, for someone who already has chronic kidney disease, what should be their awareness of other complications and comorbidities?
The first thing is, if you are diagnosed with chronic renal failure or CKD, is how early you are diagnosing it. That is the most important for the prevention of the progress. If you are diagnosed, usually the renal function test is done and the GFR is low or the creatinine is high or there is albumin in the urine, immediately, even though there is no symptoms, you should start preventive measures. The patient may be having you have to look for what is the reason for this renal kidney is affected. The most important thing which is affecting the kidney is one is diabetes, next is hypertension, third is dyslipidemia, this cholesterol and triglyceride is high, and the fourth is autoimmune disease actually. It's like SLE or IgA nephropathy, etc. So we have to check what is the reason for it and try to find the progression of the disease also. Not only you cannot save the kidney by treating the kidney because there is no measures to treat the kidney. Actually, you have to support the kidney by reversing or controlling. Actually, it all comes under the lifestyle diseases. It is always better to reverse the basic problem with the lifestyle modulation.
In a patient who has CKD, what is the role of blood sugar control in managing CKD and the other comorbidities?
See, most common disease which is causing, if you go to a dialysis center, almost 80 to 90% will be diabetic patient. Diabetic patient who will be reaching to the stage of the renal failure, they'll be having very high BP also, and there will be heart disease, cholesterol, and the heart disease also will be there. So this kidney patients with diabetes, actually this is the easiest to reverse actually. If I had seen from my experience, most of the patients who are coming to me also with the renal failure or the diabetic patients, they are unaware of the renal problems actually. Their renal function will be reduced, they will be in the third or fourth or fifth stage. And even those patients who are in the fifth stage also, sometimes they are not unaware of the renal problem because even the creatinine is 4 or 5 also, sometimes they will not be aware of the renal problem. So what is happening actually, if in the diabetic patients, the diabetic high glucose level is damaging the blood vessels, the kidney, the most important part of the kidney is nephrons, that are the basic unit of the nephron, that is made of very thin, very small blood vessels actually. So these blood vessels are damaged, and also the kidney's function is increased by excess glucose in the blood, and kidney has to excrete that. And also the medications they are taking, that also actually troubling the kidney because all these medicines kidney has to excrete. And along with that, there will be other medicines for the hypertension, cholesterol, and the heart disease and all. So the kidney has to be given rest. That is only by controlling your lifestyle diseases with the lifestyle modulation, and go ahead. If you are able to reduce the medication, then there will be definitely the kidney will be function will be improved. And if the patient is in the fourth stage we will be able to bring it to the third level, and third level to second level. And in diabetic patients especially, what I have seen is, if it is even if they are reached in the third stage just because of diabetes and hypertension, most probably they may be able to bring up the kidney function much better, rather than this autoimmune diseases. Actually, it is very difficult if it is gone down to bring up, but the kidney, this diabetic patient, bringing up the renal function is actually more easier.
Actually, when we are talking about this chronic kidney disease patients, very often, in spite of taking medications for hypertension, they find it very difficult to control blood pressure. Why is it so?
Kidney is the major, kidney has a major part in controlling the pressure itself. Actually, the basic reason for this hypertension most probably is the renal origin. What we are using as a medicine for the hypertension, actually all are working on the, at least partially working on the kidney, because hypertension is this pressure management, this homeostasis on the pressure management is the kidney has a major role by secreting renin. Renin is a hormone which is secreted by the kidney, and another hormone, protein from the liver, and another hormone from the adrenal gland. Actually, renin, angiotensin, aldosterone mechanism, and some hormones from the brain and the heart. If they are all combined for the management of the blood pressure. In the kidney patients, when the blood, actually the kidney circulation to the kidney is reduced, that is the reason for this blood pressure increase, and the renal going down of the glomerular filtration rate is the quantity of blood is filtered by the kidney per that is actually this glomerular filtration rate, or the renal function test itself is showing that how much blood the kidney can be able to filter. So when the blood circulation is reduced because of the atherosclerosis, this high cholesterol, high triglyceride, they are actually depositing in the kidney vessels, just like the heart blood vessels we say block. The same thing is happening to the kidney. That is the reason. And when the blood flow to the kidney is reduced, the renin will be secreted and the blood sugar will go high. So almost all these medicines are acting on this renin-angiotensin mechanism, or as trying to block the renin that is secreted by the kidney. So if the kidney is not getting enough blood, whatever medicine you give, the blood pressure may go high. That is in the fifth stage of the kidney disease. It's very difficult to control the blood pressure with the any medicine. I had seen many are taking 3, 4, 5, 6 medicines and all, but it is not, the blood pressure is not controlled.
In kidney patients, how do the parameters of cholesterol and triglyceride impact them?
Yes, cholesterol, actually more than the cholesterol, the triglyceride and the HDL is most important. The HDL is the cholesterol which is taking the peripheral excess fat to the liver for metabolism. And this, if the HDL is low and the triglyceride is high, then it is a problem for the kidney, because this excess will be deposited in the blood vessels. If the excess is there, why? This adipose tissue is telling that we don't want any cholesterol, we are filled and we cannot take. So there is this triglyceride cannot go anywhere. Actually, cholesterol's function is making it this dissolvable form in the blood. This oil or the triglyceride is molded into a dissolvable form in the blood and taking it. And cholesterol is taking a part in making this LDL, HDL and all. So if the triglyceride is high, the cholesterol is high, your blood vessels is getting deposited with that, it is getting narrowed and blocked. And that is the reason for the renal function failure also. The same as in the heart coronary artery block, for which we are putting the stent. And but I don't know. Now we are not putting stent in the coronary, this renal artery. The reason may be because no one is giving such a diagnosis. Only for the autoimmune renal artery stenosis, the stenting is advised now, because stenting can create this clot formation on that, and it can impair the kidney function. So unless it is very narrowed and very problematic, especially in this autoimmune renal vessel narrowing, the stenting is used, but not for the usual atherosclerosis.
We often hear that the CKD patients are at higher risk for heart disease. Why is it so?
They are under a higher risk of heart disease because they have hypertension. The kidney patients will be invariably having hypertension, and when the hypertension, the pressure, the tension inside the blood vessels to push the blood to the organs, the heart has to do more work. When the heart has to do more work, the heart muscles will get enlarged. So all the patients with the systemic hypertension, the left heart will be hypertrophic. The left heart, you can see most of the patients also nowadays to know how to read the this echo report and all. In the echocardiography report, that hypertension patients will be invariably having this left ventricular hypertrophy. The hypertrophy means excess muscle is there, so the heart is working more, muscle mass is more, so the heart has to give this coronary arteries. Along with that, the coronary arteries will be narrowed, just like the basic problem is depositing atherosclerosis in the kidney vessels. Just like the coronary arteries will be narrowed, and the heart will be, this heart muscles will not be able to get enough blood and oxygen. So the chance of heart attack will be very high in the kidney patients with the hypertension, and generally the kidney patients, the heart attack rate will be very high.
You had mentioned initially that in autoimmune disease patients, it is more difficult with respect to chronic kidney disease. Actually, patients of autoimmune diseases like IgA nephropathy and lupus or SLE and all, what is it that they should be knowing about it?
See, nowadays, because of the ANA test is anti-nuclear antibody test is positive, it is diagnosed as the SLE, systemic lupus erythematosus. That it means it's an autoimmune disease affecting any organ of the body. So now it is early diagnosed actually. I have patients, I am getting more and more patients with ANA positive diagnosed with SLE. I'm taking immunosuppressants and all. And that time the kidney may not be affected. Some patient may be having this albuminuria, but they may not be, the renal function, GFR and the creatinine level will be normal in the initial stage. Actually, we have to find out, the early diagnosis will be focusing on the albumin in the urine and the RBCs in the urine. So RBCs and albumin starting itself, we should understand that it is an autoimmune disease and should not wait for the kidney to fail, showing GFR or some other symptoms. And if you are able to correct this autoimmune process, this autoimmune process is coming because it's also a lifestyle disease. You have to find out the reason for that. What food which you are taking is actually creating problem for your cells, actually nuclear, anti-nuclear. All the cells is having nucleus. So the anti-nuclear antibody is positive and you have to correct it. And the IgA nephropathy, what is happening is this IgA, which is excess IgA is produced and that is deposited. It is acting against this nephrons. So they are getting deposited in there and actually acting against the nephrons. These antibodies, IgA antibodies, which is acting against the kidney. So we had to find out what is the reason. So if it is an early stage, we can prevent the progress of the disease if we are able to. That is, I had seen all levels of patients with IgA nephropathy also. In the early stage, it is very easy to revert, and even the ANA test positivity can be brought down to normal. And then this kidney function will actually this albuminuria will be coming normalized if it is low. It's less than 100 and all. Within 1 or 2 weeks it will be corrected. But those patients, I had seen patients with microalbumin more than 1000. It's heavy microalbumin. That and depends on the level of the GFR also. That is the kidney function in which grade, first grade, second grade, or third grade. So it is, if it is gone to this 5th stage or the creatinine level has gone raised to 4 and all, it will be very difficult to bring down. But if you find out it early, you can come out of the disease itself. And one example I can tell that one patient, she was very crying and telling that she was diagnosed with, she's only 40, in the 40s. She was diagnosed with this SLE, and she is regularly taking for the 17 years. But that after 17 years, kidney function is gone down. She has asked for this dialysis and renal transplant, and she was saying, I had done everything, then why I had to reach in this stage. Actually, this patient also, she was on heavy immunosuppressants. Actually, within a month or so, we are able to come out of almost all the medicines for her, except actually she had some this blood clotting abnormality. For that, she was taking a blood thinner, warfarin was taking. All the other medicines she was able to reduce, and when she came, her kidney creatinine was around 6.5 or so. And it was come down to around 4, and even it was reached at a time, it was 3.8 and or something like that. But according to the food and all, it will be going come and that. But she's able to maintain it around 4 actually. And it is almost an year past, she's maintaining it, she's very healthy and no symptoms. And she was taking medication for the arthritis. The arthritis is also very common with the SLE patient, for joint pain, and everything is gone. But the thing is, they had to maintain the lifestyle, and after this just 3 months or 6 months treatment, they had to maintain that order also.
Many CKD patients have a problem that, they have symptoms like itching, skin itching, or their mental facility, ability and all that is slightly compromised. Mental fog is there, and generally they feel fatigued. So, how are these symptoms related to chronic kidney disease?
One is this as a part of the disease progression. The toxins, when it is not excreted from the kidney, it will come directly to the skin, because skin is also an excretory organ. So the darkening of the skin, that is actually an early sign of kidney disease. This cheek or forehead darkening, and itching on the leg, it's all these not very early, but in the stage 3 or 4 kidney patients, these symptoms are very common. 5th stage, most of the patients will be having the skin problems also. Another thing is, if it is when the toxins are coming, the autoimmune process also start. So many patients will be having some sort of eczematous or psoriatic sort of skin lesions, either on the palm or feet or leg, and it is very, very common actually. So if there is a skin problem also, all the patients with kidney disease also, they should look for the kidney problem also, because it's actually our body is not functioning as each organ is dependent and communicating with every cell in the body. That is the hormone and all these interleukins and so many chemicals are there to communicate for them. So if there is a problem in the skin, actually skin is the mirroring all the problems actually, especially the excretory system like liver and kidney. The skin manifestation, we have to take it very seriously and find out the reason for it, and it will be, most of the thing will be autoimmune nature, and we should find out what is the reason for this immune system is misbehaving. Actually, this misbehavior of the immune cells, they are attacking our own cells, but the reason for it is the self-recognition is gone, so they are not able to find out which is self and which is non-self. That is the reason for this autoimmune IgA nephropathy and SLE and all. our own cells, the immune cells, which is supposed to be protecting us, is not able to understand that this is my own cell and why they are behaving like that. That we had to find out. That is from the investigations we'll be able to find out that basically it's all depends on our food, the toxins in our food, or it's an intolerant food may be the reason.
Actually, with your clinically supported lifestyle correction program, how do you see patients reducing on their medications?
In the clinically supported lifestyle correction, what we are doing is this we'll be investigate or with the test and investigations. This blood test, actually we are mainly depending on the blood test, and for the ultrasound scan of the kidney. For the renal patients, ultrasound scan of the kidney is very important, and we'll be seeing, and not only the kidney, we have to see what is the condition of the liver and the prostate. In men, prostate enlargement is also, most of the patients, it is also actually affecting the kidney if the prostate is enlarged and there is a obstruction to the renal flow. All these matters we are understanding. And with this microalbumin, urine protein, all this will be, before the starting itself, a basic investigation. Not basic, actually it is a very detailed investigation will be done. And then when we are, and also the food, we try to find out what food is ideal for this patient and what this food is, the patient is reacting. So we are seeing that many patients will be very common in our part of the country. The main food is the rice-based food. I've seen many kidney patients, they are having allergy to rice itself. And the milk is very common, egg is very common. And even the vegetables like simple, this lady's finger or the brinjal or even onion. And it's all depend on each patient. It will be differing for each patient. So we had to avoid those things, and also, but we had to ensure that the patient is getting a very good, all the nutrition. And the kidney patients, if they are able, if in the third stage also, it is okay. It's actually in the first and second stage patient, the creatinine is, this GFR is gone below 60. We had to control the protein also. So that is the difficulty. The protein is needed for the rebuilding of the body, even the kidney rebuilding. But if the GFR has gone below 60, we had to control the protein also. If in the fourth stage and fifth stage, the problem is if this kidney function is gone, usually potassium will not be affected if in the fourth stage also. Potassium is affected if it is in the fifth stage, if the GFR is below 15 or below 20 itself, potassium also has to be restricted. So that is the difficulty. That is why I want no one should go to the third stage itself. Before the third stage, we should be able to find out the renal patients, CKD patients. Then it will be easy, and you can maintain. As well, many of the patients we can go to the normal level itself. At least we can maintain it above 60. Then the patient will not have to restrict the essential food. That is almost 50 grams of protein everyone has to take. And that we will, for the most difficulty is in the clinically supported cholesterol correction for the patient. When the renal failure comes, if it is in the reached in the third stage, you have to cut the protein, you have to cut if the fourth and fifth, you have to put the potassium also. So in the very late stage, if it is going, actually water retention comes in the very late stage. Most of the patients above creatinine 8 and all. So then we may have to give some diuretics and all. But it is in all stages we will be able to come out of medication. Even in the fifth stage, that is the creatinine, even in the early fifth stage of the kidney failure, like creatinine is less than 5, we'll be able to come out of all the medicines, including the BP medicine, and if the patient is following everything correctly. And there are patients who will not be fully following also. I have now also an ongoing patient. She's diabetic and she got hypertension, and she is getting this creatinine. She has asked for dialysis, but She has obesity also, but she is able to, her weight reduction is low, and also she is not able to come out of diabetes, and everything is diabetic control is much good, but she is not able to come down the BP just because she is not able to reduce her weight. Why she is not able to reduce her weight? She is eating other things also, that she is taking carbohydrate, extra carbohydrate, and she is not doing the scheduled exercises. So in such patients, we are actually following the patient by the every week the blood test, especially in the fifth stage. They had to check whether their potassium level, whether it is normal, and whether it is going down. If the patient, that's everything, this clinically supported lifestyle correction, 10 patients, kidney patients, we are giving advices, and one or if they are 10, if their 10 is doing in the proper way, they will get the result. If you are, it depends on how much interest and effort patient is putting.
For someone with the CKD who is watching this program, what is it that they should be careful of into their day-to-day living so that they can improve their health?
The thing is, all the CKD patients, they will be having some of these diseases. Either they are diabetic, almost all will be hypertensive, and some may be having diabetes. And if they are not having diabetes, most probably it will be a autoimmune nephropathy. So what they have to do, actually they will be on so many medicines. So they have to, usually all these patients will be on a nephrology care. So in our standard or traditional, it's not modern medicine practice, this more the current medical practice, the medicines, they're depending always, the doctors will be giving more and more medicines to control the BP and sugar. So that pattern will not work for the kidney, that we have to understand. So I cannot give a simple solution and to tell you that especially those who are on many medication, with the clinical support only they will be able to come out of medication. So they have to find out a physician who is concentrating on that and who is able to control the sugar, whatever the basic mechanism in them, and see that their blood sugar is controlled without medication, BP is getting controlled without medication, and that is what is needed. But the patient has to find out a doctor for that. And in my experience, as I said, within a month, whatever the diseases, if the patient is following it correctly, we will be able to come out of most of the medicines actually. And very rarely, like if the patient has put test and within a year, they may have to go for this blood thinness for an year. And all the other medicines can be come down to normal. And the BP also can be controlled, provided if it's a late fifth stage renal failure, like the creatinine is more than 8, it may not be the ideal 1 to 120, 80 and all, it may not come down. But what I had seen is, if they take 4 or 5 medicine, BP medicine also, there will be, the BP will not be under control. So it is actually, the patient is in the fifth stage renal failure, what we do is, actually even the BP is slightly high also, we start the medicines, bring down the medicines. But the patient itself is saying that even if I take this 4 medicine, 3 medicine also, the BP is same. When you can reduce to 2 medicine also, the BP is same. Actually, when we reduce to, when the medicine is reduced, only the BP started normalizing. And but if they take any stress in the family, or any food with high omega-6, or then the BP can go high. So in that occasion, actually, even in the fifth stage, the patient is having a problem, and then the BP is an SOS. That in the medical terms, we say medicine is SOS. BP medicine, actually, BP medicine is not supposed to take in SOS in the standard medical practice. Every day in the correct time. But after, when we stop off all these medicines, if the patient is taking a diabetic patient taking any one day they are supposed to take whatever they like, some carbohydrate also, because always restricting will be the life will not be that enjoyable. So one day weekly they can enjoy food, and that time we take a specific glucose medicine. And if they have a stress and the BP is going high, they can that time alone. And when after that, if the BP is come down, then it is okay, then they don't have to take. That is the method we are following actually.
With this, we come to the end of this session, this third part in the series on chronic kidney disease. The first part, we looked at what are the causes of chronic kidney disease. The second part, we saw what are the latest treatments available for chronic kidney disease. In this third part, we looked at the complications and comorbidities associated with chronic kidney disease. And in the fourth part, we will see how clinically supported lifestyle correction helps in overcoming chronic kidney disease. To make things simpler to understand, Dr. Jolie often says that there's no medicine that can remove the cause of a lifestyle disease. And understanding that is the first step towards the right treatment. Now, we also realize that the informed patient is the key to treatment success through these words of Dr. Jolie. Thank you.